All right. Hello, and thank you for joining me. I decided to put together this talk on menopause and how to talk to your doctor about it after some friends. I was at a party with some friends, and they were talking about various things going on with their body, especially their nether regions. And they were feeling really frustrated that their doctors hadn't talked to them about some of the things that should have been on the agenda, things their doctors should have told them about. And to be fair, the vast majority of your doctors don't have training in this subject specifically. They really don't have training in a lot of women's bodies because we don't apparently study women's bodies. And not even your OBGYN knows a whole lot about menopause. OB-GYNs are mostly paid to catch babies, not really deal with hormones of midlife women. So I put this together for all of those friends. And then, like, when I originally posted this, like 30 extra people showed up, which was fantastic. And also kind of disappointing at how many people feel like they're struggling to get this information that they really want. Um, Now, I have a separate resource list, should be floating around here somewhere that you can find it. I'll be referring to a lot of these resources. There are resources out there about this, but depending on what kind of resource you're looking for, it can be kind of hard to figure out where they are. So before we get started, I want to mention throughout this lecture that I'm generally talking about cisgender people. We have almost no research being done on transgender people in general, but especially not about trans bodies and menopause and trans bodies and aging. Even though transgender people have taught us a quite a bit of information about why hormones are important and how they're important. So, for instance, when they first started doing gender affirming surgery on trans women, they would just cut out all of their testosterone, just get rid of it. And that kind of really screwed up their bodies. So now we have a better understanding of the role that testosterone plays in women as well. And it's incredibly helpful, around fatigue and libido. So I've tried to be good throughout this about not equating gender to genitals because there's no correlation there. And I might screw that up in a few places. I apologize for that. Feel free to call me out for it. But medically, they refer to penises as male genitalia, and they refer to vulvas and vaginas as female genitalia. So hopefully, I'm hoping someday they're going to change this, and they'll just refer to them medically as the innie genitals and the outie genitals. All right. So there are a bunch of people out there who know a lot more about this subject than I do. And those people basically have dedicated a lot of their career to this topic from a medical perspective, either working very specifically with this as doctors or doing research on it from a bunch of different angles. And those people are few and far between. I decided that my training as a sex therapist at least gave me the basics in understanding where to find this information, how to parse what was important, what was not important. But even in my training, there was very little discussion about what I'm going to be talking about tonight. A lot of the training I had like, a bunch of hours on aging and sexuality, but not really menopause and sexuality. So, um, the rest of my practice, right? What I do in my day-to-day life is really focused more on working with sexual and relationship minorities who are struggling to figure out how to work in a cishet world and helping neurodivergent people live in a world that also is not really built for them. So, caveats. Disclosures, I am not a doctor. I have done none of my own original research on this topic. I am just conglomerating some places where I've learned about this information. And I only vaguely work on this in my practice. I have women who are middle-aged who are going through this, but it's not usually like the focus of anything that I have coming in and sitting in front of me. I do, however, have a ton of lived experience with health problem whack-a-mole in my adulthood, trying to get doctors to listen to me, to give me the information I thought they should be giving me, and generally just having to advocate for my medical needs. I've had to go in and ask for the tests or the medications that I want, and it tends to be the way that things work out a lot better. So I know how frustrating it can be to not be given answers by your doctor or to be passed off as crazy. And, also to have that expectation that a doctor would tell me that there are things that they know and don't know. And if they don't know a thing, that they would tell me that. But apparently that is not a thing you see very often. So tonight we're going to talk about, what menopause and perimenopause are. You will probably hear me accidentally use these words interchangeably, even though they're not interchangeable words. They are two very different things. But that's just, and you'll hear doctors use them that way too. But I think that's just our brains wanting to shorten things down and not use the entire perimenopause word. It's a big word. We'll get a lesson in anatomy. I'm going to have you, my fair audience, Google that because I'm pretty sure that YouTube is not going to allow me to put this slide on there. Go through the signs and symptoms. I'll tell you about the good news, right? Get a quick interlude on that, and then we'll go through treatment options. And then you can ask me questions in other various ways. So, what is menopause and what is perimenopause? Premenopause just refers to the period between puberty and perimenopause, aka the reproductive years. Now, you can get pregnant in perimenopause, so it's just harder and less likely to be viable, and you're not gonna like being that old and raising kids. Perimenopause, the average start is 42 to 47. Sometimes it starts a little earlier, sometimes a little later. It usually lasts around 4 to 8 years, but it can last up to 14 years. And generally what it means is you're running out of eggs and your estrogen starts going a little wonky. Menopause is defined as the period starting 1 year after your last period. And then postmenopause is just year after your reproductive years, which, frankly, with enough hormones and the proper circumstances, you can get pregnant in your postmenopause years, which is only important if you have go through menopause extremely early in your life, but it's a difficult, region to grow anything in. So, one thing a lot of this neglects, or looking at this can neglect, is for those of us who have had procedures or on medications that stop your bleeding or lead you to bleed, quarterly. You may not know when your last period would have been, or you might not notice your periods being irregular or your cycle being irregular because you're not having periods anyway, or the hormones you're on are making them extremely regular just to the way the hormone works. So the other problem with this is hormone tests aren't really going to tell you where you're at in this process. We can take your hormones and kind of tell that you're not in menopause, and we can tell you that you're fully in menopause. But if you're on hormones, that's not going to be very accurate. And what the hormone test is going to test is like where your hormones are at that point in time, right? Like when they drew the blood out of your body, they're going to figure it out there. So that's not really useful information when you're in perimenopause, and I'll show you why on the next slide. So I find this definition of menopause to be kind of useless, given how many women are like trying to get rid of their periods even long before their periods stop on their own. So I wish we had a better definition of menopause. Now, I'm not going to get into a lot of detail on this, but there are actually three types of estrogen. And most women are primarily working with estradiol uh, through most of their adulthood. And during menopause, you're moving from estradiol to estrone. And estrone is a significantly less effective estrogen than estradiol. So your brain and your body are essentially learning how to run on a different type of fuel. And it's not just estrogen that's declining. Testosterone can also fluctuate and tank through a lot of this, period. So I'll talk a bit more later about why testosterone is important. The point here is that your estrogen is just going bonkers during this time. And so it's no wonder you're experiencing a bunch of crap. The good news is that most of these symptoms go away a few years after menopause. If you're lucky. Some people are experiencing them well into menopause. So there are a couple of types of menopause. This is what you'll hear um, well into your or what you might hear your doctor say. Spontaneous is just natural menopause when your body just starts going through the menopause cycle on its own. Medical is anytime there's an intervention that significantly reduces your estrogen. Medications that block the production of estrogen are one way that this can happen if they're really completely cutting it off. And then removal of your ovaries, which is a lot more rare these days. So if you remove your ovaries, you stop making all of your hormones, right? This is the primary place where your hormones are being made, and you'll go immediately into menopause. Back in ye old days, they used to take the ovaries when they took the uterus in a hysterectomy, even if you weren't in menopause yet. So they discovered, though, that that was leading to a lot of problems and really putting women into premature menopause unnecessarily. And it was causing all sorts of problems. So nowadays, assuming you have a doctor that's paying attention to what's going on, they will not take those ovaries unless there is some medical necessity for that. And usually that medical necessity is cancer. Other than that, they're going to keep those in there as long as they can, doing everything that they're supposed to be doing. So let's go through some anatomy. One thing you may find yourself talking to your doctor about during perimenopause or menopause is your genitals. And doctor or no, you really should get to know and befriend your genitals. They've been with you your whole life. They're try to be nice to them, right? So look into a mirror, pick out all the parts I'm going to introduce you to, and if you can get your partner to pick out all these parts on you, fantastic. Please keep that person. So if you understand the correct terminology, you are going to be able to better communicate what is going on with your doctor. Most women will experience some sort of pain in this area at some point in their life. When talking to a doctor or a physical therapist, like a pelvic floor therapist or a sex therapist about pain in your genitals, locating exactly where the pain is extremely helpful for finding solutions. People frequently use the wrong terminology with their genitals. They might refer to the entire region as a vagina when the vagina is just one tiny little part. My theory there is the vagina is the part that penis havers are most interested in being enveloped in, so that's probably why everything gets referred to as the vagina, right? So for everyone's sake, please make a practice of calling the parts what the parts are and being very specific with what part you're referring to. All right, so for those of you playing at home, you're going to need to Google vulva diagram. And if you can find this one diagram, it's the best one out there. The other thing to notice while you're here, just because you can, is how white and how symmetrical all of these vulvas are. It's really disturbing. The vast majority of people on this planet do not have white bodies. That's just disturbing that that's what they choose to depict. And the vast majority of your vulvas are not symmetrical. Okay, it just doesn't happen. And they are all different shapes and sizes. And I think if you Google the vulva project, you will see depictions of a lot of wide range of vulvas, and it's glorious, right? If you are having issues like body image issues with the way that your vulva looks, this is a great way to move past that. Remember that doing any sort of surgery on your vulva to correct anything you perceive as a flaw is likely to lead you to have a big decline in sensation down there, and that's not the greatest thing that you want. So, anyways, this is the vulva, and most vulvas are, like I said, not this symmetrical or white, but the vulva itself refers to everything in this picture from the mons pubis at the top down to the perineal raphe at the bottom. So this is also sometimes referred to as the taint. So parts that can be really important to identify include the hood of the clitoris and the clitoris itself. The hood can actually be pulled back so you can inspect or clean the tip of the clitoris. Now, the clitoris is really densely packed with nerve endings, so you need that hood there almost to protect you from how incredibly sensitive that this part can be. So the clitoris looks pretty tiny from here, but it actually extends back into the body and wraps around the vagina. This is why you get separate clitoral and vaginal orgasms. And they feel different because the contractions start in different places of the clitoris. Now we have the outer labia and the inner labia. And inside the inner labia, below the clitoris, is called the vestibule of the vagina, the fleshy part around the vaginal opening. And it contains several very important parts. So, obviously, very important is the urethral opening. And on either side of that, are the Skene's ducts. So remember some of these names. We're going to cover them later in the talk. And the last part I really want you to make note of is the Bartholin's glands just below the vaginal opening, which can interestingly or annoyingly can get affected or irritated with some mood regulation medications. So if you're pretty convinced that your like mood regulation medication is giving you cysts in this area, and your doctor is telling you no, they aren't, that's BS. They pretty much are. So all around this region, hopefully under your skin, are your pelvic floor muscles. And they're very important for making things happen, right? They control how well you pee and how much you can like clench down within your vagina, and they help your legs move around. So I want to make a quick comment about your pelvic floor and Kegels because people really like doing Kegels or thinking they're doing Kegels. Many women carry a lot of tension in their pelvic floor muscles, including the Kegels, and this can lead to problems with difficulty in urinating, and it can also lead to a lot of pain on penetration. So working out your Kegels can actually do a lot more harm than is worth it. So only do Kegel exercises if your pelvic floor therapist is encouraging it. And while we're talking about the vulva specifically, a problem that can happen at any time but comes up more often in menopause is called lichen sclerosis. This causes white, thickened, itchy patches of skin that can crack and bleed and appear around the vulva. So these are usually treated by steroid creams. As soon as you start seeing them, get on them, and don't let them get away from you, or you'll end up scarring the tissue down there, and that can lead to a decrease in sensation. All right, next we have the inside parts. There's a lot fewer of them that you need to know, and hopefully they're okay with this picture being on YouTube. The vagina is basically where the canal, where the penis, sex toy, or please other improved insertables go. You can fit a whole lot of things up there, but please only stick to things that are actually built to be in there, I guess. Figures are okay. They're not exactly built to be in there. It's very easy to throw the biome of your vagina and your vulva out of whack. This is how you give yourself things like bacterial vaginosis or yeast infections. And in fact, good side note, anytime you're introducing a new partner to your vulva and vagina, even if it's only through hands, you're being colonized by their biome. And sometimes your body, especially if you have an immune condition, really struggles to fight that off. And it can lead to this weird colonization thing that happens. And you can end up with a pretty severe bacterial vaginosis. And if you don't know the difference between BV and a yeast infection, and you go to the store and you're like, oh, I'm going to get yeast infection medication, right? Really wiping out one can exacerbate it if you actually had the other. So until you really can tell the difference in yourself, always go get tested and make sure you know what it is before you just go try random crap off the uh, drugstore shelf. So the cervix is the gateway between the vagina and the uterus. You can also have cervical orgasms, by the way. Some women like it being touched. For others, it's quite painful. The uterus is where babies are incubated. It's also where your menstrual blood builds up and then sheds during your period. Your ovaries hold all of your eggs and are responsible for making all of the estrogens and testosterone. Your fallopian tubes allow the eggs to travel to your uterus for implantation during pregnancy or discarding. They'll be discarded on menstruation if they don't get used. There's also some interesting new science that ovarian cancer might be originating in the fallopian tubes instead. I think that'll help us really refine surgeries and we'll have even less ovary surgery, taking your ovaries out. I can't pronounce the word that they use for that, so I'm just not even going to try. Um, if unused in menopause, the vagina will most likely shrink in size and the walls often get much thinner. And this process, you're much more prone to prolapse. So none of these organs that you're looking at here are really tied to anything else in your body. You don't want them tied to anything else in their body. You want those to be able to move around and flex with you as you're moving. So they're mostly held in place by your other organs, some fat, and some friction. And so when they do a hysterectomy, they're not really stitching anything back in place because, like I said, you want that all to move around. That also means you're more likely to prolapse during or after a hysterectomy. Um, and so this is why it's not unusual also for your vagina and uterus to come out of your vaginal opening during childbirth, right? The force of that birth can take all of these bits with it or open up things enough that it falls out later while everything is trying to shrink back into place. So lubrication comes out of several different places. And this is important as you recognize that you're starting to lose some of your lubrication as you age. So the walls of the vagina are the main place. And then externally, you have the Bartholin's glands and the Skene's glands that produce a lot of lubrication. In fact, we think the Skene's glands are involved in ejaculation, but of course, we don't have enough science to really tell us whether or not that's true. Um, we aren't really 100% sure about how each of these glands works or when they decide to lubricate. So, like I said, as you age, the walls of the vagina thin out and become less able to secrete lubrication. And you just aren't making as much lubrication with the lower hormone levels. So you're not getting lubrication out of any of these places as much. And then the hormonal fluctuations that you're experiencing on the way to menopause are likely leading to an inconsistency of lubrication. So some days are fine, and other days it's just not happening, right? So the other thing to recognize is during this time, during menopause, the lack of hormones that you have, right, assuming you haven't gone on HRT, leads the entire vulva to shrink back down to what it was. In your prepubescence, you probably don't remember this because you weren't paying much attention. Your genitals are quite small, and then the introduction of testosterone and estrogen, especially testosterone, makes them grow larger and fill out, and then they start coming back down. I mean, technically, you don't need any of that plumbing anymore. At least your body doesn't think you need it anymore. So your labia can almost completely disappear back into your body, which sometimes freaks women out if they were paying attention to their labia in the first place. The other unfortunate thing is that because your vaginal opening is closer to your urethra, you tend to get a lot more bacterial exchange between the two, which leads to a lot more UTIs and just general irritation of the whole area. Additionally, the vestibule of the vagina is extremely sensitive to testosterone. And if there isn't enough, it'll get irritated, it can get sore and swollen. So if you're experiencing pain with penetration, this is a very possible culprit. especially if you're putting a lot of lubrication in the area and it still feels irritated. Another common reason to experience pain with penetration is associated with trauma around guarding yourself from penetration, which this is where the Kegels come into place, right? They're doing that guarding for you. And if you've been guarding for a long time, it can lead to these consistently overtight Kegels. So being able to differentiate between pain due to low testosterone and pain due to trauma can be very important because they're treated in very different ways. So your best bet in getting this diagnosed properly is going to an OBGYN, especially if you can't think of like if you can't think of a time that you've ever struggled with penetration and you're just now starting to feel this penetration, like this has never been a trauma for you, chances are it's the testosterone, but you need the OB-GYN to check the strength of those muscles and see what's going on in there and get a really good look at the region. Another important thing to talk about are the networks of blood vessels and capillaries and nerve endings that are extremely dense throughout the entire vulva and vagina. Age alone tends to cause some havoc on our nerve endings and our blood vessels, leading to a loss of sensation. If you have some form of like cardiovascular disease, diabetes, MS, spinal cord injury, if you've been through any sort of cancer treatment, or have anything else that leads to nerve damage, you may even lose a lot more sensation in this area. The nerve bundles come in the region come in a few sizes. The smallest ones that are very sensitive to like light touch and like, anything a partner might do to you, they tend to disintegrate first. The large ones stick around for a while and they do a really good job of feeling vibrations. So vibrators can come even more in handy as you age if you're noticing a decrease of sensation in the area. And especially if you're struggling with orgasm, they can help you feel enough to bring about your orgasm. So a reduction in blood flow in the vagina might also mean you lose some sensation in there. So previously, you may have been able to get off with vaginal orgasms. They felt great, but now you're really struggling with vaginal only orgasms. You have to make sure you're moving to the outside and focus on the clitoris from the external access port. The great news is that using a vibrator on your vulva and in your vagina with regularity can actually help increase circulation to the areas, can help keep these tissues healthier, especially if you're choosing not to do any hormonal therapy. Now, another reason this is all important to know is that even if you have no intention of ever having sex or even masturbating again, you don't care about orgasms, it may be helpful to try a hormonal intervention here if you're like experiencing pain in the region. Um, and you can vibrate your vulva and vagina to keep everything kind of in working condition, right? If you're having frequent UTIs or a loss of sensation, this can keep you from continuing that decline. If you're dealing with arthritis or you have trouble reaching your vulva with a vibrator, there's actually a great company called Ergo Erotics that has tools for you, tools for your tools, right? And they can help you make sure you can reach this area and hold on to your vagina and hold on to your vibrator. Remember, right? Doctors are not trained in sexual health or menopause. They don't know anything at all about sexual health unless they have taken specialty training on it, right? So don't expect them to ask you these questions, right? Women have historically been left out of medical trials because of the risk to pregnancy. So literally all scientific trials done pretty much in the last 50, 60 years have all been done on men, despite the fact that their bodies are running on a completely different mix of hormones, right? And they react very differently to a lot of medications. And this isn't just about hormones, right? A lot of medications respond differently depending on the hormones that are involved. So there's just a lack of information out there for doctors to even know where to start. So they also aren't taught to ask about or assess for sexual health problems that might arise downstream of aging or menopause or other diseases. And I'm just going to throw out some numbers here for you. 80% of the training a urologist does is on penises, and they get paid better for treating penis problems. 80% of urologists also said that they would not know how to do a thorough vulva exam to check for vulva health if they were asked. And given how many times the vulva and its relation to the urethra is involved in UTIs, that's kind of disturbing, right? They can absolutely assess for the health of your penis, but not the health of your vulva. So if you are dealing with sexual health problems or menopause, you need to find a doctor that says they specialize in it. It is okay to ask your doctor if they have had any experience or additional education in treating the thing that you are wanting treatment for, especially around sexual health. Um, and the part of the problem that you see is that sexual health and menopause don't seem to be owned by any one specialty out there, right? And you'll see when we come to the signs and symptoms of menopause that like these things are all over the place. They're all over your body. And so no one person, they just kind of bat you around to different specialists. And no one person is going to address the fact that it might be perimenopause that you're dealing with. So if your doctor says that they don't have any, they haven't bothered to take any special training in menopause or sexual health problems, you can request a referral for someone who does. Um, it's unfortunately very difficult to find a PCP or an ARNP on your insurance, like especially on your insurance's website. Um, and there's very little in the way of directories out there to find someone who specializes in this kind of stuff. And if you're here up in Seattle, it is nearly impossible outside of going to a gender clinic at a hospital to get anyone who looks at this kind of thing, which is in Seattle, that's disturbing. It's a huge city. So the signs and symptoms can start at any point during perimenopause and can last well after your last period. So, up to 30 women do not experience identifiable symptoms ever. And I really envy those women. If you had terrible menstrual problems or postpartum problems, you are more likely to have terrible perimenopause problems. And we're not really sure what causes this variation because why would we bother to research that? So, cardiovascular symptoms involve the irregular heartbeat, hot flashes, night sweats, migraines, tingling sensations in the limbs. And the reason hot flashes fall under cardiovascular, right? A hot flash is just this, you feel like you're having a burning sensation or a real warming sensation come up in your chest, maybe your hands and feet and your face, and it can last for a couple of seconds to upwards of 15 minutes. Really unpleasant. But this is actually a cardiovascular response. So, one of the things that hormones can regulate is the dilation of your veins and capillaries, right? And if your hormones are going wild, that dilation is up and down and up and down and up and down. And a lot of hot flashes, night sweats, and migraines can be triggered by this dilation and uh, constriction and destriction of your veins, right? Um, it's important to be able to differentiate these symptoms from actual cardiovascular problems that may be developing due to aging or poor health. It's actually not uncommon for menopause symptoms to indicate an underlying problem that otherwise may have gone undetected around your cardiovascular system. The interesting thing about hot flashes specifically is that 15% of women will never ever experience them. 33 don't experience them until they're pretty close to menopause. And 25% of people end up with these super hot flashes that start early, happen often, and last long after menopause. Feel like that is describing me. Um, One thing that surprised me is that most people didn't realize that there were significant cognitive symptoms associated with menopause. Brain fog, mood swings, irritability, struggling with your words, sleeping difficulties. Actually, sleeping difficulties can go into a couple of these because everything can ruin your sleep. Panic disorder. A lot of women won't start developing panic attacks until they're into perimenopause. Libido changes, again, can go into several of these, right? If you're losing sensation in your vulva, you might lose some libido because you're just not having as much fun anymore, right? And memory changes. Um, so, and I'm going to repeat this several times throughout this talk, but getting enough sleep is the single most important thing you can do for your mental health and your physical health. And it can be really hard to sleep when you're having night sweats and migraines and hot flashes. So, when it comes to brain fog and memory changes, many women start to think that they're going crazy. They feel like they're significantly underperforming from what they were used to. And then you start to notice that the way that your memory works is changing, and that can be really freaky. Estrogen and probably a bit of conditioning leads a lot of younger women to have better memory around conversations and episodic memory. Episodic memory just refers to being able to remember things that they happen in like an order, right? Events in your life. So this type of memory actually fades out a little bit as the estrogen fades, and it feels like your memory isn't quite so crisp. You can't seem to hold on to things as much, but you're actually still doing just fine. It just feels that way. So they do these many cognitive tests. A lot of women will score like a 30 on these, 30 out of 30, not unusual throughout their entire adulthood. And then during menopause, that score will dip down to a 28. But the at 25 is where you're actually like looking at significant cognitive decline. So 28, like you're still doing just fine. You can get through your day without any problems, but you're feeling frustrated that you're not holding on to things like you used to. And just so you know, on this test, they start to see cognitive decline really kicking in by the age of 60. So that is a separate thing from what you're experiencing during menopause. So the biggest thing you'll see is this ability to retain things in your short-term memory. I can tell I'm having a good day when I don't have to go back to that like two-factor verification test and reread all the digits to make sure I'm entering them in correctly. But on a bad day, it'll take me 2 to 3 times of getting that number in there all the way. And it's only a 6-digit number. So, as I discussed in the anatomy section, there may be a lot of changes around sexuality during this time. Like I said, the sexual desire can really fluctuate wildly for a lot of reasons, depending on how well the pain is managed, how well the dryness is managed, and your libido, right? Like your hormones do have something to do with your libido, but not as much as you might think. So, this up and down can really change the way that you're experiencing your libido. And many women through this period decide that they don't ever want to have sex again, right? The way that their hormones are changing, they're just like, I'm done with relationships. I'm going to go be more dependent. I don't really need to care about this stuff anymore. Women who really appreciated sex before menopause and really enjoyed sex and really, made sure that their sex was enjoyable will tend to work through the struggles that they're having through perimenopause and early menopause, and they'll come out the other side being a lot more confident about sex. And especially if they have a partner that they can communicate with about all the changes in their bodies and make these adjustments. So again, you could choose to not have sex if you don't want to. That is totally up to you. If you want to continue having sex, just remember it's going to take a lot of communication with your partner. A couple of other random things on the list that are signs and symptoms, right? Your hair might start thinning um, as you lose estrogen. Changes in how you urinate. Either you can become, it might be more difficult to urinate, or it can become, you can start having incontinence problems. joint pain, muscle stiffness, digestive issues, tinnitus, new allergies develop, changes in taste and body odor occur. Your voice will often lower at the other side of it. You can get dry mouth, a lot of itchiness just all over your body. And breast sensitivity can really start to happen. I know I've been getting these shooting pains in my left breast. I haven't had those since I was like 22 and like randomly lactating. I've never been pregnant, but I would randomly lactate. And so it's been like wild to have this weird breast stuff going on at this age. All right, so I don't want to be this entire talk to be doom and gloom. And so, like, this is a time of great change, and you have a lot of opportunity to make a lot of positive changes in your self-care and your life around this time, depending on your circumstances, right? If your children are out of the house, you never had children, it's often a time women just decide that they don't want to, put up with a lot of things anymore, or they realize that they need to make these changes. So that's a good time to think through what that might mean for you. So in surveys, the one of the things that many women cited is the best thing about menopause was just not having to deal with periods or being worried about getting pregnant, right? And I'm gonna uh, interject this with an interesting fact, right? And if you want to have a lot of casual sex in your old age and don't have a partner, move into a retirement community. A lot of sex that happens in those places, and they have the STI rates to back it up. So even though it's great you can't get pregnant, it's important to remember to keep using condoms if you are having sex with multiple or new partners and want to avoid most STIs. The other nice things that happen with your lower estrogen is that you tend to just not give as much of a crap about taking care of other people or putting up with their drama. So you cut these people out of your lives a lot easier without all the guilt that goes along with it. And sometimes this includes husbands that haven't been pulling their weight for a while. So this can give you more time to focus on yourself and your own priorities, especially if your kids are out of the house. And so with so much time not taking care of others, you get to focus on making positive changes for you, developing better habits so that you can enjoy your golden years a lot healthier. Once you're all the way through menopause, your body settles into a new normal. Your energy levels and mood tend to really even out and improve. The gray matter in your brain that has been disappearing through perimenopause, this is part of why you have many memory problems. It starts to come back. So gray matter is responsible for the coordination and movement of your body. It's good for memory retention, cognition, and mood stabilization. So believe it or not, this has been kind of going away for you the whole time through perimenopause. All right. Now, interventions. Remember, you do not have to do any of these things. You don't have to take HRT. If you aren't having symptoms or the symptoms aren't really bothering you that much, there's no real point in doing it, except for like a few, can help with a few other things. If you choose not to intervene, you will likely want to get tested for osteoporosis early to make sure you don't need to treat that. That's one thing that estrogen does help prevent is bone loss. I personally like taking estrogen and pregabalin for my perimenopause symptoms, and I expect that I'm going to be on them for the rest of my life, and I am fine with that. So, hormone replacement therapy is just as it sounds. There are thousands of options out there, I feel like. And so I'm not going to go over any specific medication because it's more between you and your doctor, your individual circumstances, and there's just too many medications to sift through. So I'm primarily going to focus on types of medication, generally what they help with, and delivery methods. I do have a few specific recommendations that aren't hormonal because they were recommended by doctors that I've taken classes from. And I also have some personal experiences with a few things. So this is just to give you a better idea about what you might be asking for from a doctor. If you come to a doctor saying you want to try something specific or try a specific type of delivery method, they are likely to take your lead unless there's something that they're seeing in your chart that is a massive contraindication. Now, if you want to give hormone replacement therapy a try, you will need to realize that this tends to be a rest of your life thing. You can stop the hormones if you're completely in menopause, but you will then have some pretty extreme withdrawal symptoms associated with, again, abruptly putting yourself into a different type of estrogen. So just understand what you're getting yourself into. You're basically supplementing what your ovaries are doing through an external way, external source, right? So it's best to start HRT when you are noticing the signs of perimenopause, while your body is still used to processing estradiol, right? If you get past this process and your body quits having sensitivity to those estrogens, it doesn't come back just because you introduce it back into your system. So studies have shown that starting HRT after the age of 60 tends to have none of the positive effects that you normally get from estrogen supplementation, but all of the bad effects, right? So if you're already on birth control when you start perimenopause, you should talk to your doctor about whether or not a change is even useful for you, right? So most of the time, your doctor is going to start you on something that is a combination of estrogen and progesterone, and this combination reduces uterine cancer. Now, if your uterus has been removed, you don't need the progesterone component. And so they won't worry about that. They'll just give you the estradiol. Now, estrogen has gotten a bad rap due to a whole lot of really bad science that came out in the late 90s and early 2000s. I'm not really going to cover any of that bad science. What I am going to tell you about are the most recent studies done in the proper populations and with lower amounts of estrogen showed that there was maybe a very, very, very slight increase in breast cancer or uterine cancer, but it is massively outweighed by the extreme decrease in mortality due to having stronger bones and some better cardiovascular health, depending on the delivery method of the HRT. You actually have more risk of developing breast cancer if you live a sedentary life, drink 2 glasses of wine at night, or carry a lot of extra weight around your waist than if you're taking hormone replacement therapy, right? So your lifestyle factors have a much bigger influence on this than the hormones you're taking. Now, there are several ways that your hormones might be delivered to you. Most common are pills and creams, but there may also be options for patches, rings, or IUDs. Pellets have also been an option that are sometimes still used, but every doctor I took a training from said, do not ever use pellets. Just stay away from them. Only go towards other options. So it's really important to understand why you might choose a pill over a cream. So a pill is seen as a global delivery method, affects most of the systems in your body, and goes through the liver, where a cream is a localized delivery method and affects mostly just what it's touching. So they are, granted, getting really good at developing pills that focus on a particular type of estrogen or a particular set of organs and are specific to different indications. You only worry about that kind of stuff if you're having other health problems that you need to consider with this. Because all pills go through the liver, it can lead to long-term liver problems and even some cardiovascular problems as side effects. However, these global estrogens, right, in the pills are much more better at effectively helping cognitive symptoms and fighting off osteoporosis. On the local delivery method, you got your creams, your hormonal IUDs, rings, and vaginal suppositories. Creams are often rubbed on the vulva or inserted into the vagina to deliver the estrogen directly to the vagina and uterus. Many of these are really helpful for increasing lubrication and preventing UTIs and incontinence. They tend to cause fewer cardiovascular problems, but they also don't help as much with the osteoporosis or cognitive problems. Overall, locally applied HRT is often much better tolerated than a global HRT. And remember that the vulva primarily runs on testosterone. Low testosterone is not an uncommon in menopausal women. Low libido and high fatigue can be a sign of low testosterone, though these aren't always correlated. The level they usually prescribe for supplemental testosterone also tends to not lead to the same cholesterol problems that men get if they are because they take the testosterone in much higher doses. If you want to try testosterone, the key phrase is, I have very low libido. It's the only reason insurance will cover testosterone if you're a woman, right? It comes in a cream or gel that you rub on your arm or calf. Do not ever actually rub this into your vulva or your clit unless you want a much larger clit. Now, they like to differentiate birth control, which is usually hormonal, from other forms of progesterone or estrogen. Not all hormonal interventions prevent pregnancy. So if they are offering you a hormonal intervention that you don't know very well, and you plan to have PIV sex without condoms, the question to ask your doctor is, does this prevent pregnancy? Because you might have to supplement if it's not doing that for you and you're expecting it to. And one of the problems we come up in with this population is the first things an uneducated doctor will prescribe when women are coming to them with complaints of like irritability and cognitive problems or panic disorder or other difficulties in regulating temperature are SSRIs and SNRIs, right? These are your anti-anxiety medications, antidepressants. Now, venlafaxine tends to be the one most commonly prescribed at this point, and it's one I'm very familiar with. It absolutely will help your mood and your hot flashes, but they come with a lot of unwanted side effects like weight gain, excessive sweating, and rectal bleeding. Um, and if hormones aren't an option and you're having a lot of mood problems, or you had mood problems already before you even got here and now they're just untenable, this is an okay one to go with, but other medications should be explored first. If you didn't have mood problems before menopause, you are probably going to want to come off these in a few years, and these are extremely difficult medications to come off. Venlafaxine was the biggest nightmare to come off in my life. It ruined me for 2 months straight. I could not function. This F medication on here that I'm not even going to try to pronounce has been specifically formulated for hot flashes and is not a hormone. So if your chief complaint is hot flashes and you don't want to be on hormones, this might be a good option for the temporary treatment of this where you could come off of it once you're done with this era of your life. And then the last two on this list, gabapentin and pregabalin, are great, more generalized medications and that can help with a lot of symptoms and don't have a whole lot of side effects. Gabapentin and pregabalin really good for pain and anxiety, especially pain. So if you've had chronic pain most of your life, can try one of these. Generally well tolerated by most people. And the nice thing about the gabapentin is like there's dose ranges between 100 milligrams and like 2,400 milligrams, something way up there. And so you can really dial in an amount that works for you. And they can help quite a bit with mood as well. So I spent all weekend in the seminar with many doctors and researchers who are all working on this. And they universally said, don't buy into supplements or other wellness products that advertise themselves as treating your menopause problems, with a very small number of exceptions, and I'll get into that. But I'm going to get on my soapbox for a second to tell you why. Supplements may say that they're FDA approved, but that only means that the FDA has determined that this thing you're putting into your body isn't going to kill you. Products like homeopathy have actually been routed around FDA approval by laws passed in the 1930s to exempt them from needing any sort of approval at all. They aren't even tested for possible death. So remember, none of the claims made by these supplement companies are scientifically tested. Most of the supplements have no quality control over what ingredients are actually in them. The only regulation in the supplement market is self-regulation. And I've added a place you can go check to see if a brand you are using is getting a third party confirmation of ingredients listed. Um, because one of the biggest problems that they have in this industry is like you don't there's no testing to make sure that what's going into the pill is actually the thing that they're advertising in the bottle, right? um Also, the supplement industry is one of the top three donors as an industry to right-wing politics, to ensure that they aren't ever regulated. And I say this full well recognizing that hashtag not all supplement companies donate to right-wing politics, and that hashtags not all supplements are hogwash. I have supplements that I take because I have the MHTFR gene and I can't methylate my B vitamins. So there's a lot of things that I need to take to account for that. Most of the useful menopause supplements come in the realm of vitamins and minerals that are fairly standard building blocks for our bodies. The science done on these isn't so much as about supplement efficacy as much as it is about, like, we've done a bunch of science on what happens when you don't have these things in your body. As we go through menopause, the bacteria in our gut change, and it's not unusual for us to have difficulty absorbing various nutrients. So adding some of these in can really help out your symptoms. So now I want to make clear what I'm saying here. Nothing that claims to help with menopause around like hot flashes that is sold over the counter has shown any efficacy whatsoever, unless it happens to have a combination of some of these ingredients, which are not specific to menopause, right? So magnesium is a mineral that generally helps with sleep and muscle tension, and there are several different kinds. If you're chronically constipated, magnesium citrate tends to be a good option. Magnesium glycinate has less of the stool loosening properties and is very good to take right before you go to sleep, help you get sleepy. There is a type that has been more recently developed called magnesium L-threonate that if you take it during the day can help with the cognitive functioning and memory, and in addition to some of the sleep and muscle tension benefits. And then there's a different kind that, like, if you're rubbing it on your skin or you're taking a bath in Epsom salts, you can get your magnesium that way. Um, Now you do have to be careful. It is possible to technically overdose on magnesium, but you've got to really take a whole crap ton of it before you start hurting yourself. If you generally get leg cramps, just try magnesium. I also keep a bottle of the citrate around just in case, but I generally use the L-threonate. Omega-3 with DHA and EPA is good for your cardiovascular health and your immune system and can help with mood, especially depression. And it also helps out with the inflammation of the joints. So this can be really useful if you aren't getting a lot of seafood in your diet. St. John's wort has also been found to improve mood, though it can interfere with SSRIs. It's also very hard on the liver. However, it doesn't have as strong an effect as SSRIs, and it's easier to come off of. So if you're feeling moody specifically during perimenopause, you didn't have a whole lot of mood problems before perimenopause, this might be a good one to use through this period because you know you're going to come off at the backside, and you can come off of it a little faster and easier. Some doctors have found that B12 and vitamin D levels are consistently showing up as extremely low during perimenopause, likely due to the difficulties with digestion, like I was saying. They're both incredibly important to mood management. B12 also is important in nerve transmission, cell function, and protein metabolism. Even outside of perimenopause and menopause, if people come into my office and say that they're struggling with their mood, the first thing I have them do is go test for B12 levels and D levels, because it's hard to do much of anything else if these two aren't where they're supposed to be at. If you have the MHTFR gene, I'm not going to get into this much deeper than that. You will need a methylated version of your B vitamins, or else you're just not going to be processing them at all. There are some additional options for managing vulva health and increasing lubrication. DHEA is a precursor to both estrogen and testosterone, meaning that you are likely to make more of each if you're supplementing with this. Now, understand that there are two ways that medications work, right? They either increase the amount of the thing that you want to increase floating around in your body, or they work on helping you actually use what you have in your body, right? And so DHEA is helping you increase the amount floating around in your body. It's not necessarily doing anything to help you process it better. And this is a good option if you want to see if something will work. If it, is it a hormone thing, and you want to try out something that's fairly cheap and over the counter before going full on prescription hormones. If you're already taking prescription hormones, this can interfere with their efficacy. So it also doesn't help to take it orally as much. You might feel a bit more energetic, but you'll get more efficacy out of this medication if you insert the pills directly into your vagina, which can kind of get gritty and messy if it doesn't completely absorb into the vaginal wall. There are also DHEA suppositories, which are really great. And you shouldn't worry about, if you have a penis and you're putting it into a vagina that has this in there, it's probably not going to affect you that much. There are CBD products that can help when rubbed into the vulva or inserted into the vagina, and they think what's going on is it's helping with nerve transmission, but they aren't really certain. These can help with general moisturization or lubrication, depending on the product. Fioria has a whole line that has been recommended by some doctors. There is a study coming out very soon that happened at my alma mater that marijuana can help with libido and enjoyment of sex. The study, unfortunately, is based off self-report and doesn't track what kind of THC or CBD was ingested or even how it was ingested or used. As you're aging, you will likely need to supplement sexual activity with a lot of lube. One problem that comes up often in this area is that it can be difficult to differentiate a moisturizer from a lubrication because many companies use these labels interchangeably. Moisturizers should be used every day and generally not for sexual activity. Think of them more of a maintenance item for your overall health. Lubrications are primarily used to aid in insertion in your sexual encounters and should be used liberally before and during insertion as needed. Many water-based lubricants use chemicals to help them be more slippery and for that slipperiness to avoid getting gummy. The word osmolality refers to the ability of the lubrication to draw water out of the cells. The osmolality of your vagina is about 200, which is fairly low. Many lubrications have osmolalities of up to 1200, which means they are likely doing a lot of damage to the cells in your vagina. KY jelly is actually a pretty bad culprit in this. So if you want to use water-based lubes, you want to find lubrications with an osmolality closer to 200. And in your resource list, there's a link to talking about how all of this works and a list to resources on which lubes are better for not destroying the cells in your vagina. Now, water-based lubes are great for not destroying your silicone toys or condoms, which is why a lot of people use them. But again, they often get sticky really quickly. Oil-based lubricants can last a lot longer and don't have any of the osmolality concerns, but they can also break down condoms, and they're likely to stain your clothing and sheets, so you'll want to lay down a towel. Silicone-based lubricants can also last a long time and will also break down condoms. They should not be used with silicone toys, and they do a pretty good job of sticking around forever. The main point of all this, though, is don't use whatever is in your kitchen cabinet, please. It can cause a lot of infections. It really isn't safe for vaginal insertion. That part of your body is extremely sensitive, and you want to only use the man-made things, if you have man-made things, only used for what's actually supposed to be in there. And not even all of those are particularly safe. Now, let's get to some of the lifestyle changes you can make to help you get through menopause. I'm going to push through these last three slides fairly quickly because I feel like much of what is widely known, uh, or you've likely heard it repeated ad nauseum for various reasons. But I do want to emphasize that there are vast amounts of scientific data that we have to support the fact that attending to good sleep, eating a healthy diet, and exercising regularly can be just as successful, if not more so, than taking a pill for most of your health problems. And I know the problem most people have is that it takes 2 or 3 months to really see the difference, if you see a difference at all. And in the meantime, you feel like you're suffering through difficult things that don't give you any joy, like the exercise, or suffering without the things that you really do enjoy, like snacks, right? Potato chips are freaking tasty. If you're really interested in making changes in these areas but struggle with habits, I suggest checking in with a therapist on how you might keep up some of these habits, and they might also help you be able to hold yourself accountable to habit building. Often, when I hear about people wanting to practice self care, these three things are barely on the list, and they should really be at the top. So, the number one thing, like I've said, that you can do for your mood and your health is to get good sleep. This should be your top priority, no matter what stage of life you're in. But it's a thing that becomes exceptionally difficult when you're getting into perimenopause. Obviously, it can just really, really a lot of things going against you there. So basic things that you can do to help with your sleep. But if these things don't work, you should be going for medical help. If you have sleep apnea, you should be figuring out how to get and wear a CPAP consistently. Sleep apnea destroys your cardiovascular system. Using a CPAP can help with the night sweats and the hot flashes. It's also important to differentiate between trouble getting to sleep and staying asleep, as different meds can help in different ways. So when you're talking to your doctor, make sure you're telling them what your difficulty is around sleep. If you go the medical route, there's so many options, including a lot of off-label options for medications, that you really need to talk it over with your doctor. Melatonin can be a fine supplement to help you sleep, but it comes with a problem of rapid habituation and addiction, right? So you take it, you got to take more and more. Eventually you're taking some, as much as the label tells you you can, you go off of it and you have this rebound inability to sleep. So take it for a few nights at a time here and there, you're probably going to be fine. You can also try to find a therapist that is trained in CBTI. If your main problem in getting to sleep is, maybe something coming up in your environment, you need to maybe check for what in your environment might be a problem, or you're having cognitive problems like racing thoughts. You want your bedroom to be as free from distraction and noise as possible. For some of you, I need something to distract my brain. If your partner is a big problem and you getting to sleep or staying asleep, you might need to figure out how to sleep separately from your partner. If that idea is causing fights, go see a couple therapists. Cognitive problems include, like I said, the racing thoughts, and it doesn't really matter if they're anxious thoughts. My brain likes to yammer at me for hours about pointless things that don't matter. I have no real emotion associated with them. It's just very, very distracting and I can't get to sleep. So I have to put on a podcast and like give me, the first ad in, I am out because it distracts my brain long enough for me to get to sleep. Another thing to remember is that everyone needs a different amount of sleep, right? And if you and your partner need different amounts of sleep and you're trying to sleep in the same bed and one of you's up when the other one is down and at different times, it's going to disturb your sleep. So figure out how many hours you need and go to bed at the time that makes sure you get enough sleep to wake up at that time. Now, a few nights here and there of getting a little less sleep, not a big deal. You can make up for it a little bit later. But it's really important. Exercise, right? This is the one of the biggest things you can do for just aging in general. It helps with every single aspect of aging, and can also significantly help with hot flashes, sleep problems, and bone density problems associated with menopause. And like I said, this is not about losing weight. It's about keeping blood flow throughout your body to help maintain your cardiovascular system. It's about maintaining muscle mass so you can stay active. And it's about strengthening your bones. Breaking bones after the age of 65 is probably one of the most dangerous things that can happen to you, and it is associated with a very high mortality rate. And you don't have to go crazy with the exercise. 30 minutes a day, most days of the week, doing a brisk walk will help you significantly. Adding in 30 minutes of resistance training 2 to 3 times a week with dumbbells or resistance bands doesn't have to be heavy weight. You can do body weight exercises and get a lot of this. And the other nice thing about exercise is you don't have to do it all at one time, right? If it's hard for you to fit this into a very specific time of your day, it might be easier to like take quick 10-minute breaks at work a couple times a day, walk briskly up and down the stairs, do some bicep curls, do some squats, right? As you age, things like high intensity training become a lot less useful and a lot more dangerous. Uh, High intensity training has mostly been studied on like healthy young men. Again, why would we bother to study this on aging bodies or women? Neither of these people are important in our society. You also want to work on your flexibility and balance because that can help you by preventing falls that break bones. Again, 10 minutes of stretches in the morning, 10 minutes of standing on the Bosu ball at a break at work, right? 5 minutes of standing, not even 5 minutes, a minute standing on one leg, a minute standing on the other leg, right? As you're at your standing desk, right? Or what I like to do is just sign up for a Pilates or a yoga class. I find that having the external accountability of signing up for a class and being expected to show up there, or I'm taking someone else's place, can really help me get out of bed and maintain a routine. When the rest of the time, it's really easy for me to talk myself out of it because I'm not being responsible to anyone else. And finally, diet. Diet is really important too. And again, this is not about sticking to a fad diet or trying to lose weight. This is about putting high quality foods into your body as fuel, right? If you're not digesting your food as much or as well, you need to get more out of your food, right? So processed foods shouldn't be considered fuel, right? If it comes in a box or a bar, it is probably processed. Most processed foods are stripped of nutritional value and full of chemicals that at best are empty calories and at worst are actively hurting your organs. So sticking to mostly veggies, chicken and fish from meats, substituting in whole grains and legumes instead of meat where you can give you a very nutritious meal and can fill you up pretty well. And there are tons of easy ways to make these things tasty, right? With herbs and spices. You want to stick to complex carbohydrates rather than simple carbohydrates. Simple carbohydrates will spike your insulin and then can mess with your insulin system. Complex carbs are whole grains like brown rice, quinoa, legumes, whole grain wheat. They're full of fiber. They take a very long time to digest and they encourage your gut health. Simple carbs are grains that are stripped of their nutritious outer shells. And this includes white flour, white rice, sugar, right? Simple carbs spike the blood sugar, wear out the insulin system, and can more easily lead to diabetes. And the spike in insulin can also lead to spikes in fatigues and migraines and various hormones and neurotransmitters, right? So when you're in perimenopause and you've got all these things working together, you're just up and down everywhere, and your body doesn't know how to deal with it. The diet generally most associated with good health outcomes, you've probably heard this, is the green Mediterranean diet. It's the Mediterranean diet with less meat and more veggies. And there's a link on to a 2-page sheet to help remind you of what goes into this diet. It's pretty simple and straightforward, right? Get your meats, get your vegetables, get your whole grains, get your beans, call it good. Reducing caffeine can also help regulate your mood and anxiety so you're not going up and down on this. Cutting down on drinks that aren't water in general can help you just not have so much sugar running through your system. Um, Intermittent fasting can be the wrong option, especially if you're having emotional swings. Hangry, plus irritable already because of your mood swings and your hormones shifting around is not good for anyone. Again, intermittent fasting has also been mostly studied in fit young men, not in aging women. So you're better off opting for smaller meals and more often. And I really, really hate to say this as a wine drinker, but you should significantly limit your alcohol. The correct amount of alcohol consumption is technically zero. Uh, I still drink, so I don't want to be, you know, a hypocrite on this. But alcohol consumption is directly linked to a lot of cancers, including breast cancer. It's just not healthy for you in any form. And also it can spike your blood sugar and is basically just more empty calories. All right, so that's all I have for you. Here's a couple of places you can find me, get a hold of me if you have any additional questions. Otherwise, I hope you've enjoyed this little talk. Thank you.